So welcome back to Pharmacology with Dr. Sokolow, and this is the last part of the anti-infectious agent. And first, we're going to talk about the drugs that are used for the treatment of tuberculosis. So let's first start with tuberculosis. So what is the cause of tuberculosis? The cause is the Mycobacterium tuberculosis, and as you may know, tuberculosis is highly contagious. The main target of this bacteria is of course the lung, but occasionally it can also target other organs, and you can see in some cases you can have those rashes in the lower legs. How do you diagnose tuberculosis? So it's the tuberculin skin test, where you would look for an induration after 48 to 72 hours of the intradermal injection. And of course, the definite diagnosis is by doing a chest x-ray and also looking at sputum culture. Because of the emergence of resistant to the anti-TB agent, treating tuberculosis is not easy and requires a combination of several drugs. So the first line agent to treat tuberculosis is isoniazid. This is a drug that has a bactericidal activity. So bactericidal mean it kills the bacteria. And in this case, this drug inhibits the synthesis of mycobacterial wall. Adverse effect, the most common adverse effect are peripheral neuropathy, and so it is why we give pyridoxine, also known as vitamin B6, to reduce the risk of peripheral neuropathy. There is a black box warning regarding the liver adverse effect. It can cause severe hepatitis. And also isoniazid is a potent CYP enzyme inhibitor. So as you already know by now, any drug that is a CYP enzyme inhibitor is going to cause a lot of drug interactions. The second agent that is used for the treatment of tuberculosis is rifampin or rifampicin, which is the long-acting analog of rifampin. Those drugs has bactericidal activities, and they actually inhibit the RNA synthesis by blocking the RNA transcription. Adverse effect can cause hepatotoxicity. And one thing that you have to be aware is that it can stain contact lens and clothing, because it can cause red-orange body secretion. So if a patient is complaining that they see orange in their contact lens or on their clothing when they sweat, it's because of rifampin or rifampicin. The next drug is pyrazinamide. It's also a bactericidal drug, and its exact mechanism of action, it's unknown, but it's used for the treatment of tuberculosis. Also cause hepatotoxicity. So if you look, all those three drugs are causing liver toxicity. And then the last one is ethambutol, which is a bacteriostatic, so inhibit the growth of this tuberculosis bacteria. And again, this is a drug that we don't know the exact mechanism of action on how it targets, the Mycobacterium tuberculosis, but we know that it has a bacteriostatic activity. Now, in terms of the anti-tuberculosis regimen, as I mentioned, the patient has to take several drugs several times a day, and this is a major issue regarding adherence. And so in order to increase the adherence of the patient, the patient has to be observed. So it's called the directly observed therapy. And this is now the standard of care. So that means the patient is going to take their dose in presence of an observer. And they have to go 2 or 3 times a week. Before it used to be they have to go every day, but of course, it's also a commitment. So they are going to be observed 2 or 3 times a week. And this is really increased the adherence of the patient with their anti-TB therapy. So for uncomplicated pulmonary TB, there are two phases. Either the patient can have a latent TB or an active TB. So for latent TB, as you can see, the treatment, it's pretty long, and they would take as a neoside up to 300 milligram per day. And this is also the preferred regimen for patient who has HIV or for children. Um, and they can also take, or they can take rifampin 600 up to 600 milligram daily for 4 months. Now, when it's an active TB, this is when the patient has to take several medications. So you see here it's a 4-drug regimen called RIPE for rifampin, isoniazid, pyrazinamide, and ethambutol. So they're all 4 drugs. And you have first an induction phase with, those 4 drugs for 2 months. And then they have the continuation phase for 4 to 7 months, which is only with isoniazid and rifampin. Now, when resistance is a concern, which can happen, then you would add another antibiotic, which is moxifloxacin. And so when it's a tuberculosis which is multi-resistant to those antibiotics, they are much harder to treat, but I'm not going to go into the details. So for now, just focus on what are the options for latent TB versus an active TB for the uncomplicated tuberculosis. Now, let's switch gear and now move on to the antiviral agent. And we're going to start with the drug for non-HIV viral infection. So antiviral therapy are much complicated than for treating bacterial infection. And that's why there's only very few drugs that can treat viral infection. And the reason why it's because, viruses infect the cells and they use the biochemical machinery of the host cells to replicate and to reproduce within the cells and then infect, adjacent cells. So it's really difficult to suppress the viral replication without doing significant harm to the host cell. And because of those antiviral, they're going to suppress the biochemical processes that are unique to the viral reproduction. So first, let's talk about the drugs that are used to treat herpes simplex viruses, so HSV1 and HSV2, and then that also active again, varicella zoster virus. So the prototype drug is acyclovir and brand name Zovirax. This is a very popular drug for treating those viruses, and they are acyclovir. It's available PO, IV, and topical preparation. Now there is a similar drug which is valacyclovir, and this one it's only available PO, and this is a prodrug of acyclovir, and this is Valtrex. So what is the mechanism of action of those two agents? So acyclovir, it's a purine nucleoside analog, and so therefore it's going to inhibit the viral replication by inhibiting the viral DNA polymerase and the incorporation into the growing viral DNA strands. And so therefore it's going to inhibit the DNA synthesis, and so the virus is not going to be able to infect any more cells if its synthesis is inhibited. So the adverse effects, oral acyclovir, it's pretty safe. It's devoid of any serious side effect. The most common one include headache, nausea, and nausea, vomiting, and diarrhea. Now, what are the indications? So, as I said, they're used for treating herpes simplex viruses, HSV1 and HSV2, and then varicella zoster virus. So, varicella zoster virus. Now, there is, vaccine to prevent varicella in children, but we see, the occurrence of shingles in adults, and that can be really painful. So again, now there is also a vaccine to treat shingles, but for those who are not vaccinated, like for elderly who are not vaccinated, you would give high dose of acyclovir to treat shingles. And the oral therapy is also effective for chickenpox in children, but with the vaccination, you don't see as much occurrence of chickenpox in children. HSV1, so this is the herpes labialis, usually occurs around the mouth, and you can take oral acyclovir to prevent the recurrent herpes labialis, also known as cold sores. Or you can apply like a topical acyclovir cream when the patient start feeling the first sign, the prodrome signs in the lips. You can some like tinkles in the lips, and then that's when you would apply the cream before having like the vesicle that burst on the lip. That's when it's the most effective. No, HSV2, this is known as the genital herpes. In this one, you would give oral acyclovir to reduce the severity of the initial episode and also to reduce the frequency of recurrences. But it doesn't eliminate the virus or cure. So, it's an STD, and you always have to educate your patient of avoiding the transmission and using safe sex precaution. So now let's talk about the treatment of cytomegalovirus infection. So CMV, or cytomegalovirus, is also a member of the herpes family. In the US, 50 to 85% adults age of 40 and older are born the virus. What happened is, like, after the initial infection, where sometimes you have barely any symptoms, the virus remain dormant for life. Same, with the herpes simplex virus, especially HSV1, like the herpes labialis, the infection, the virus remains dormant, and then it can be triggered from different factors. And in the case of CMV, this virus can be reactivated in immunocompromised patients, especially in HIV patient, cancer patient, or patient who are using immunosuppressive drugs. The drug of choice is valganciclovir, which is, the prodrug of acyclovir, so has the same mechanism of action. And this drug, it's used for the prevention and the treatment of CMV. Hepatitis. So hepatitis, there are like 6 different hepatitis viruses, A, B, C, D, E, and G, and only B, C, and D can cause chronic hepatitis, and there are also vaccines that are available for Hep 1 and Hep B. If you work in the hospital, hepatitis B is recommended by the hospital if you manipulate blood, because you want to prevent, infection with Hep B. Now, Hep C is the one that is causing, the most problem in the United States, and this is also a hepatitis virus that is transmitted through blood. But there is no treatment, and you can get infected through, a needle. And it's estimated that 2.4 million Americans have chronic hepatitis C. This chronic infection progresses slowly, and in some patients can cause liver failure, cancer, and death. There are like 6 different genotypes of Hep C, and type 1 is the most prevalent in the US and in Europe, and it's also the most difficult to treat. Now let's talk about the drugs that are effective against Hep C. So you have the interferon alpha 2A and 2B that are given sub-Q. So what is an interferon? So an interferon is a compound that is naturally occurring in the human body, and they are actually signaling protein that are released by a host cell in response to pathogen. And so in this case, they will be released they would be triggered by the Hep C virus, and so they have complex antiviral, immunomodulator, and antineoplastic activities. And by giving them to a patient, by giving a recombinant form of interferon alpha 2A or 2B, those recombinant interferon would bind to the receptor on the host cell membrane and then block the viral entry into the cell, block the synthesis of the viral RNA and viral protein, and later, block the viral assembly and budding of the virus from the cells. So as a therapy, they are given sub-Q, and they are combined with ribavirin as a booster. So it's also an oral agent with direct antiviral activity. But however, this ribavirin doesn't have any, is not effective when it's used alone, but when it's used in combination with the interferon, it's just a booster and potentiate the activity of these interferon alpha 2A or 2B. Now you have conventional versus long-acting interferon. So the long-acting interferon are called the PEG interferon. So because it's a pegylation, so they are conjugated with a polyethylene glycol, and this will delay the elimination of those interferon. The advantage is they have a long half-life, and then their administration, it's once a week. So for compliance, it's a big deal. Adverse effect of those interferon, they can give like flu-like syndrome effect, neuropsychiatric effect. They can depress the mood and cause some suicidal thought. There is a black box warning that they can cause or aggravate autoimmune disorders, infectious disorder, or ischemic cerebrovascular event. And when they are used in combination with ribavirin, they may cause birth defects. So of course, they are contraindicated in pregnancy. Now, ribavirin, like I said, this is also an antiviral agent, but it's only effective when it's combined with sub-Q PEG interferon alpha, or interferon alpha. PEG is the long-acting form of interferon alpha, or the newest oral anti-Hep C medication that I'm going to cover after this slide. So what is the mechanism of action of ribavirin? It's an inhibitor of the Hep C virus polymerase. So the polymerase is the one that is involved in the RNA replication, and so therefore, by inhibiting that enzyme, it inhibits the viral RNA replication. Ribavirin plus PEG interferon alpha was the regimen of choice for chronic Hep C until the approval of sofosbuvir, which is a oral protease inhibitor that we're going to discuss in a couple of slides. Now, the adverse effect of ribavirin, they can cause hemolytic anemia, which can occur within 1 to 2 weeks of therapy. So it's important to monitor the red blood cell count. And then there is a black box warning that it's cause significant teratogenic effects. So it is a drug that has to be avoided in pregnancy or in women who are wishing to become pregnant. Now, here are the newest agent. These are oral agents, so it's a big deal because, everything that has to be injected, not, the favorite route of administration for the patient. But with the approval of all those oral medication, this was a game changer for the treatment of Hep C. And so there are different type of protease inhibitors. So you see you have the NS3/4A serine protease inhibitor, and this is simiprevir or paritaprevir. So this, you see I underline Previr, so you should know that when it's Previr, at the end, that means it's an S34A serine protease inhibitor. So they are indicated for the treatment of HCV in combination with other HCV agent. They are not used as monotherapy. Now also with the, especially the genotype 1, Hep C genotype 1 is very complicated to treat. And like HIV patient who has Hep C, they need to take a combination of different medication to be effective. And what is the mechanism of action of those NS3/4A serine protease inhibitors? So they are inhibiting that NS3/4A serine protease, and therefore prevent the HCV replication and maturation. The adverse effects include fatigue, nausea, vomiting, anemia, headache, and then you can have severe like skin rash. Now, the other group of serine protease inhibitor are the NS5A. So for the 5A, you see you have Azvir, so unbeat Azvir, and it is used in combination with paritaprevir, which is your NS3A inhibitors, and ritonavir has a booster, so it's a protease inhibitor, and this is called Viekira, or you have Arvoni with ledipasvir, so it's another NS5A inhibitor, so you see they have the same ending, which is used in combination with sofosbuvir. This one is NS5B inhibitor, which is going to be discussed in the next slide. So you see those drugs are used in combination with other to be effective, and so this one is Arvoni, so ledipasvir with sofosbuvir. It's another like combo that is used for the treatment of Hep C. And those NS5A serine protease inhibitors, so they inhibit this particular protease and also prevent the virus maturation. So they are used for the treatment of chronic Hep C in combination with other Hep C drugs. So you see here you have the combo, and they are not effective as monotherapy, just like the NS3/4A inhibitors. Adverse effect: headache, fatigue, nausea, vomiting, and anemia. And then the last class are the NS5B inhibitor with the prototype sofosbuvir, which is also an oral drug. And then you have dasabuvir, again, you know, I underline the common ending. And B, you have the B for NS5B. And so this is a prodrug that is converted in the liver. They are potent on all genotype, including the one that are resistant to the PEG interferon. And they are more effective than the PEG interferon therapy when combined once daily with ribavirin for 12 to 24 weeks, depending on the HCV genotype. So as you can see, this is also like long-term therapy because it's a chronic Hep C infection. So hepatitis C, it's a chronic infection, so they require a long-term treatment. So you see here 12 to 24 weeks. And with this, you can sustain a virological response of 90%. So the mechanism of action, so it just inhibits a different polymerase, which is the NS5B, and block the replication of the virus. Indications, so again, first-line agent in combination with other HCV drug, not as monotherapy. So the message here, you don't use those PO medication alone, you're using them in combo. And on the previous slide, I gave you different combination that are approved by the FDA that include, you know, either an NS5B plus an NS5A or NS5A plus an NS34. And the adverse effects are fatigue, diarrhea, anemia, and headache. So here you see this is the replication cycle of the Hep C virus. So first, the virus has to attach to the surface of the cell, then it will fuse with the cell membrane, and you're going to have that's how the virus enter the cells. After that is going to release its genetic material that will try to be incorporated in the nucleus of the host cells. And you see this translation is mediated by the NS34A protease, and this is inhibited. So this step is inhibited by the NS34A protease inhibitor, such as boceprevir, telaprevir. So you see they all have the previr in their ending. And then the next step is the replication. So once the genetic material of the virus integrate the nucleus of the host cells, is going to be able to replicate within the host cells, and this replication is inhibited by the NS5B polymerase inhibitor, because the NS5B is mediating this step. So the NS5B polymerase inhibitor inhibit this step, and these are sofosbuvir and dasabuvir. And then the next step is the morphogenesis, which is mediated by NS5A and blocked by the NS5A inhibitors, such as daclatosavir, lipizavir, and ambivistavir. And then lastly, you see is the butt of the virus. So these are like the different steps that can be inhibited by those drugs, and when they are used in combination, you just block several steps of the replication of the virus, and that's why they are only effective when they are used in combination. Thank you for listening, and I will see you in the next module on antiviral therapy.